Hey guys, we're going to talk about chapter 35, and this is going to focus on just those key pediatric nursing interventions. There are several interventions that you're going to have the ability to do in your pediatric clinical experience. This chapter really focuses in on medications, IV fluids, some of those really high-end interventions that we have to be just very intentional with. So I'm just going to get started here. So we all know that there are rights of medications. Those should be familiar to you. There's also the rights of pediatric medications. So the normal ones that you all know about are right medication, right patient, right time, right route, right dose, right documentation. The other ones I want to talk to you about are right approach. So we know that you're going to approach pediatric patients in different way depending on the age. You're not going to approach a 2-monther the same way you approach the 2-year-old or the 12-year-old. So you have to take that right approach, especially when it comes to medications. Parents also have the right to be educated. So again, don't take a cup full of pills into the room, because inevitably the parent's going to say, oh, what's that pink one for? And you're going to have no idea. So make sure you've got everything still in the original packaging so that when you go into the room, you can talk to your patients about what you're giving, why you're giving it, and give them some education. Parents also have that right to refuse medications for their kiddos. That's kind of a, is this medication important enough that I need to give more education so that they don't refuse it? Or is it Tylenol? They're starting to feel a little better since you went and drew it up, and they just don't want to give it at this time. So that's going to be really a nurse judgment call when we have refusals that might be going on. It also may be a conversation with the provider if the parent does refuse certain medications. So before we can even think about giving medications, nurses need a solid understanding of growth and development to really ensure safe administration of medications to children and to give developmentally appropriate explanations for the medications to children and their caregivers. So why is the drug needed? What will the child experience? What is the expectation of the child? How can the parents participate and support their child? So those are some of the developmental things that we want to consider as we're giving those medications. So why is medication administration in peds so important? The smallest error could cause very significant damage to these pediatric patients. So I've got a few case studies that I'm just going to walk through. This top one here is a 17-month-old that was seen in the emergency department for periorbital cellulitis. The nurse took the vital signs and the weight, and she documented the weight as 25 kilos instead of 25 pounds. So 225 milligrams of clindamycin was ordered. The parents saw the mistake on the paperwork the following day and called, and they changed it to 113 milligrams TID. Did this kill our patient? Clindamycin is an antibiotic, so no. But did it create some abdominal cramping that was unnecessary, some diarrhea that was unnecessary? Yes. So just being aware of that 25 kilos versus 25 pounds was quite a significant overdose. This one here is the 20-day-old post-op tetralogy of Fallot, which is a heart condition with several different defects, and they were given 50 to 100 times the dose of indomethacin. This patient went into renal failure, but was able to recover. Damages, not fatal, but damages. This is a picture of a 6-month-old that was given an adult dose of an antibiotic for pneumonia. They went into cardiac arrest and passed away. And if you haven't heard of Josie's story, I know I talk about it a little bit in my concepts class, but Josie's story is a pretty sad story. It's an 18-month-old that just really had a total breakdown in the health system. There was a lack of communication and many errors that should have been avoidable. And unfortunately, she also passed away, and it all resulted back to a medication that she was given. So you can see just based off these 4 cases how important being mindful of medication, dosing, just how careful you have to be when you're passing meds to our pediatric population. So we also know there's differences in pharmacodynamics and pharmacokinetics, and this should be familiar from your pharm class. Absorption is medication into the bloodstream. Distribution goes from the bloodstream into those interstitial spaces and cells. Metabolism can be altered in children, and then excretion comes through the kidneys. Remembering our pediatric patients' kidneys may not be fully mature, so we have to be careful of toxicity. So some of the factors that affect absorption are listed here. Obviously, we know that oral medications are slower gastric emptying. So if we give an oral medication, it's not going to be a fast result because of that slowness through this system. Intramuscular absorption goes into that muscle mass. You're going to see a little bit faster absorption. But we also have to make sure we have really good muscles when we're giving those medications in that manner. The other ones there are listed, and I'll let you read those. So factors that can affect distribution of medication. Children have a higher percentage of body water than adults, so more rapid extracellular fluid exchanges happen. They also have decreased body fat. So remember, we also are maturing all of our organs. So the liver is immature, which can alter that first pass elimination. Physiological factors that affect metabolism. We can think about differences in our hepatic enzyme production. There's increased metabolic rate, which can alter metabolism in our kiddos. And then biotransformation. Children's kidneys are immature until usually about 1 or 2 years of age, which could affect our renal blood flow, glomerular filtration, and active tubular secretions, meaning this may result in a longer half-life and increase the potential for toxicity of drugs primarily excreted through those kidneys. So let's talk about determination of the correct dose. You can see here that we can determine our correct dose based off of body weight or body surface. And we're going to really focus just on body weight. Body surface is more for our very specialized oncology floors with our chemo medications. So when we're thinking about determination of body weight, this is the most common method for calculating our medication doses. This is what you will see when you go to clinical. Most medications are expressed over 24 hours or single dose. So you'll see milligrams per kilogram per day or milligrams per kilo per dose. So how do we do this? We weigh our child. If the weight is in pounds, we have to convert it to kilograms. Please don't forget to convert your weights to kilograms, especially if a question on an exam comes up and your weight is in pounds. If your weight is in pounds and you don't convert it, you are not going to get the correct answer and you're going to overdose your child. So make sure you convert it to kilograms. You're going to check your reference range. There you should have a low safe dose and a high safe dose. You're going to find out what your order is, and if that order goes right in the middle of that low and that high, then you have a safe order to give that medication. So let's do a couple of examples here. You have a 6-year-old that weighs 25 kilos. They've ordered 300 milligrams per dose, and your safe dose range is 10 to 15 mg per kg per dose. So when we think about this, I'll give you a second if you want to pause the video and figure out, is this a safe dose? So the 6-year-old is 25 kilos. The low dose is 25 times 10, which is 250. The high dose is 25 times 15, which is 375. 300 falls right in the middle there. So this is a safe dose. The next example is a 12-month-old weighing 12 kilos. The order is 156 milligrams per dose. Your safe dose range is 10 to 12.5 mg per kg per dose. So pause the video here, see if you can figure out, is this safe? So when we do the math, 12 times 10, that low dose is 120. 12 times 12.5 is 150. The order is 156. That goes above the safe dose. So this is not a safe dose. And like I said earlier, body surface area, we're not going to get into. This is based off of height and weight and using a line. You can see the line here. Really, this is where chemo meds come into play. So I am not going to focus on this. You don't need to focus on this. I just want you to be aware there's another way to determine dosing for kiddos. So what is the impact on medications? Infant and young children require very small doses of medication. So I'm going to say that again. They require very small doses of medication. So if you're on your exam and you get this, I'm going to give 650 milligrams, I would probably re-add that because that is a large amount of milligrams to give to a child because they require small doses of medication. You want to make sure you're comparing that ordered dose to the recommended dose. If it seems unsafe, you probably need to do your math again. If you do the math again and it's still unsafe, what do? We contact the physician or the practitioner that ordered it and find out why they're giving such a large dose. Oral medications can come in the way of liquids, elixirs, syrups, and suspensions. We can also see powders, tablets, and capsules. You'll find that some parents are like, oh yeah, he can swallow pills and he's 5. That's really still unsafe. If they have swallowed pills at home, great. That's under the parent's watch. If they aspirate on your watch, then that becomes more of a problem. So make sure you're anybody younger than 5 or 6, they just need to have those elixirs, syrups, or suspensions. So when we're giving those medications, we do want to make sure that we use calibrated equipment to dispense the medication so that we're giving a very accurate amount. You're going to direct that liquid towards the posterior side of the mouth and give the drug slowly in small amounts. Allow the child to swallow before you continue to give more medication into that mouth. So different formats, other different formats besides oral that you might see as rectal suppositories. Typically that's not the preferred method. If you have a child that's vomiting and has fever, we may do rectal Tylenol. Clearly if we have a child that's seizing, we may be doing rectal diazepam. But the absorption can be very erratic and unpredictable rectally. Ophthalmic are drops or ointments. Room temperature, I don't know if you've ever taken eye drops that are out of the refrigerator. It's not very comfortable. So make sure they're at room temperature, position the child properly, and then just make sure you're controlling their head and hands. So you may have to put them in a little bit of a swaddle or phone a friend to help with this. Try to attempt to administer that when the child's not crying. Otherwise, they cry and it just rolls right back out with those tears. You can put them supine, hyperextend that neck, rest the hand on the forehead, kind of retract that lower eyelid in order to get those ointments in for sure. As far as otic, those are going in your ears. Those are drops typically. If you are 3 or younger, you're pulling that pinna down and back. If you are greater than 3, then you are pulling that pinna up and back. Side lying or back, same position for several minutes. Massage the anterior part of the ear just to promote the passage of those drops. Nasal drops or sprays, make sure you have the child blow their nose first or really suction them out. The last thing you want is for that medication to just hit those boogers that are up in their nose and it goes nowhere. So make sure you're really clearing out that nose before you put them in. If they're drops, supine with that head hyperextended. If it's sprays, you can do it upright, head tilted back, occlude the nostril, have them deep breathe through that nose and then spray it. Here's a couple pictures just showing each of those different methods of putting the eye drops, eye ointments, ear drops, nose drops, and then those suppositories. Remembering that Sims position is your best position for suppositories. Intramuscular injections, hopefully you've given these previously. If not, take the opportunity if it arises. Remember, we're giving that medication into the muscle. Typically, we don't give a lot of intramuscular injections with medications. Those are mostly vaccines. Making sure you're going in at that 90-degree angle. Injection sites, if they're less than 7 months old, that vastus lateralis muscle is the best muscle. Anything greater, we can add the ventrogluteal. Doesn't mean we don't use the vastus lateralis. We can just introduce the ventrogluteal as a secondary site. We're going to not ever use the dorsogluteal because of the damage of that sciatic nerve. So again, just some pictures of the sites. You can see that top one is the vastus lateralis, dorsogluteal, deltoid, and then ventrogluteal. And you can see kind of a comfort hold there by the parent as they're holding that child. Kind of that side hug lying, but really have hold of that hand and that leg. Subcutaneous and intradermal injections should be familiar to you as well. Subcutaneous, right, it's going in that fatty layer of the body, usually used for insulin, heparin, some immunizations. Intradermal is going right up underneath the dermis. TB skin testing, or TB testing and allergy skin testing. Making sure we're providing atraumatic care whenever we're giving these injections. Children's Mercy has a comfort promise. You may hear your clinical instructors use that. Every time that we are going to provide uncomfort to our patients, then we need to provide them some type of comfort to get them through it. So making sure the parents are kind of participating in the care if they're able to. They can use comforting positions. We can also apply some topical anesthetic prior to any injections, making sure we're educating the child and the parents about what we're giving, and then preventing any medication errors. And we've talked a little bit about that, just education a lot, right? If we're educating, then we're hopefully preventing errors for us and for the parents once they leave the hospital. Peripheral sites for IV. This is just a picture of all the different sites that you can give your IVs for your kiddos, or where you may see your IVs. So principles of atraumatic care. I talked yesterday in class about making sure that you are not the nurse that is unprepared when you're going in to start an IV, or if you're going in to manage the IV. So make sure you have all of your equipment before you approach the child. There's nothing worse than not being prepared in the eyes of the child and also in the eyes of the parent. If you look incompetent, then they're going to be concerned of you taking care of their child. We typically select hands rather than the wrists. We can also select some of those upper arms, but we start low and move up high. Make sure we've given them adequate pain relief. So Emla cream, sprays. We have something called the J-tip, which is a lidocaine that just goes right up underneath the skin, and that will help relieve any of that first poke. We can use a barrier to avoid pinching the skin, especially when we're putting on the tourniquet. So putting a towel under, washcloth under, maybe using their sleeve to put under the tourniquet just so it doesn't pinch that skin. You can make 2 attempts, and then you have to find somebody else to try if you are unsuccessful with those 2 attempts. You can encourage parental participation as long as they're not hovering, they're not getting in your way. Definitely distraction, talking to the kiddo are great parental participation points. Securing the line with minimal amount of tape. You probably know if you've ever had an IV and they just tape you up, it just pulls all of the hairs off of your arm. So minimal amount of tape to keep it secured and then just protecting that site. Emala cream is a mixture of lidocaine and prilocaine. So it's a local anesthetic, a numbing medication that you apply to the skin. It does take a lengthy period of time to really start working. So a lot of times we can do these for like vaccines because we have the time. If you're needing an IV and you're not in a big rush to get the IV, you can definitely do it at an IV site as well. So IV fluid administration. So it's really important to understand that we need to monitor our fluid status. So how do we know how much fluid our patient needs in a 24-hour period of time? It is based off of weight. So the formula for the 24-hour fluid administration is 1 to 10 kilos. The first 10 kilos get 100 mils per kilo. So up to 10 kilos. The 11 kilos to 20 kilos get 50, and then anything greater than 20 kilos, you're going to add 20 to that. So let me show you a little bit of practice. If our child weighs 8.4 kilos, that's going to fall below less than 10. So all of that's going to get 100 mils per kilo. So 8.4 times 100 gives me 840 milliliters in a 24-hour period of time that this child will get fluids. If I want to know what that hourly rate is, then I just divide it by 24. So 8.4 times 100 equals 840 mils. That is my daily fluid maintenance. If I ask for it on an exam question, what is the hourly, then you need to divide it by 24, and that gives you 35. Okay, next one. A child weighs 16.3 kilos. So the first 10 kilos get 100, so that's 1,000. Then we have 6.3 left over. That 6.3 falls in that 11 to 20, which means all of that's going to get 50. So 10 times 100 is 1,000. The remaining 6.3 kilos gets 50, which is 315, and that gives me 1,315 mils in a 24 hours. If I ask you to give me the hourly fluid, then it's 54.7. So this is really important when you get to Children's Mercy and you have IV fluids running. If your patient weighs 16.3 kilos, you should be doing the math. If you walk into your patient's room and you see that your pump is running at 54.7 mils per hour, then you're golden. If it's running something different, then you need to investigate why. So last one here, child weighs 32 kilos. The first 10 get 100, so there's your 1,000. The next 10, because it's greater than 20, get 50, so there's another 500, and then anything greater than 20, that's left us 12, right? 32 minus 20 is 12, get 20 per kilo. So you can see there, 1,000 plus 500 plus 240 gives me 1,740s in a 24-hour period of time. If it's hourly, it's 72.5. So while we're maintaining that IV fluid therapy, we want to monitor the rate, the volume closely every hour. If you have fluids running, you should be checking that site every single hour. My story is that I checked my, 14, 15-year-old's IV fluid 1 hour. It was doing great. I walked back around the next hour and his arm was twice the size as it should have been. It was cool, it was puffy, it clearly had infiltrated. So had I not gone back in an hour and looked, who knows what could have happened to that arm. So vital for you to check your fluids every hour when they're running continuously. It's going to avoid those complications of infiltration or inflammation. Remembering that infiltration is that infusion going into the surrounding fluid or surrounding tissue, makes it cool, makes it puffy. Inflammation is the opposite, warmth, redness, there's an induration, and it usually is very tender. We would have to stop our IVs and discontinue it if we've noticed either one of those. So there's just some pictures of an infiltration versus an inflammation, although both of those really look like inflammation with the red and the appears like it could be warm. Anyway. All right, providing nutritional support. You will see probably some enteral tube feedings when you get to Children's Mercy. Remembering those can be nasogastric or orogastric, you probably won't see very often. Nasojejunal, you can see, and then gastrostomy or jugostomy, meaning it's right there on the abdominal wall. So remember how if you have the opportunity to place an NG, by all means, go for it. Remember how to measure it though, from the tip of your nose to your earlobe to your xiphoid process. If you are going to your jejunum, which is your NJ, then you go to the xiphoid process, you measure to the umbilicus, and you go right in the middle there. And then you'll definitely check placement prior to inserting any formulas or medications. Yeah, so checking tube placement is essential. The last thing you want to do is put all of that formula into your patient's lungs. Once it's in, you can't take it away. So making sure that you're checking tube placement. You should confirm it with each use. If it's a continuous, then obviously you're just going to check it with that first use. For the most part, you guys probably learned in fundamentals that radiology confirmation is the most accurate, and it is. With kiddos, though, it does come with a risk. Radiation can cause growth stunts. So a lot of times we don't do radiological confirmation, so don't be surprised. We'll check it with measurement, and if it's measuring the aspirate in the gastric content is measuring correctly on the pH paper, we're going to fly with it without doing that x-ray. So it's just some different guidelines here to finish up here. Verify correct placement, give the liquid medications into the tube, make sure you drop the right amount, and then make sure you're also flushing that tube, right? The last thing we want is to have medication just hanging out in that tube and the child's not actually getting it. The rest of the slide kind of talks how we can't shove a capsule down the tube, so what do we do? We can't shove a pill down the tube, so what do we do? So hopefully you get the opportunity to be able to crush some meds, open some capsules, and place these medications in some tubes. And that completes chapter 35 on these key pediatric interventions. If you have any questions, shoot me an email, and I am happy to answer them. Thanks, guys.